Good morning, everyone, and thank you to the meeting for giving me the invitation to be here and present on this topic. So today we'll shift gears a little bit and we'll talk about the post-dissection thoracoabdominal aortic aneurysms. These are my disclosures. We've heard a little bit about some of the, okay, I'm sorry, there you go. Okay, so we heard a little bit about the aortic dissections earlier this morning. So when you have these patients who present with type A aortic dissections and some of the patients that will present with type B aortic dissections, a significant number of these patients, 20 to 55% of these patients, can evolve into thoracoabdominal aortic aneurysms that need to be addressed. And the rupture risk of these patients is listed up here as well. The open repair for these can be associated with significant morbidity and mortality. So, in the current era, as Dr. Odrich has already talked about, the significant change that the endovascular era has brought about in terms of taking care of the thoracoabdominal aortic aneurysms should be considered. Now, is that applicable to the patients who have post-dissection thoracos? I think that is something relatively newer compared to the degenerative thoracoabdominal aortic aneurysm. So we'll talk a little bit about that. So when you have patients with type A aortic dissections, for most part, traditionally, patients have had repairs for their ascending aorta. Sometimes they'll have a hemiarch or short hemiarch or some variation of hemiarch. So when these patients have aneurysmal degeneration, they will require some sort of an arch intervention as well. And I think we've heard a lot about this in the past session. So I'm not going to dive into it, but I'll just kind of leave it up there that you can repair them in an open fashion, or you can repair them in an endovascular fashion. The endovascular approach for those patients will require anatomic considerations, and a lot of planning and sizing is absolutely critical. There are multiple arch branch devices in clinical trials that we heard about before. So let's talk about now the post-dissection thoracoabdominal aortic aneurysms. Open repair, as alluded in the previous talk, has significant mortality that is associated with it. Whether you're looking at high volume centers versus low volume centers, 19% is pretty significant for a 30-day mortality. So what do we do? So we can have different variations and iterations of endovascular approach that can address this problem. So you can do TVAR with false lumen therapy if your aneurysmal degeneration is limited largely to the thoracic aorta and not involving the thoracoabdominal aorta. So you can use Knickerbocker technique, you can use candy plugs, or if it's involving the thoracoabdominal aorta, then you'll have to do some sort of a fenestrated or branched endovascular repair. So here's an example of a patient who we did a Knickerbocker technique for repair of the thoracic aortic component, which was actually 6 centimeters. And if you can see that the patient actually had arch repair done. He had a hemiarch done, so we were able to do this with a zone 0 repair, and then we did Knickerbocker with some false lumen therapy in this patient. Now, this patient, as you saw earlier, will probably need something down the line, but at least this way he is staged, and I think that's a very important concept also to understand, and we'll get to that. Candy plug is another technique that has been used quite a bit in Europe and to some extent here as well, but those are associated with significant re-intervention rates, and false lumen thrombosis rate can be as low as 60% in certain cases as well. So then let's come to the fenestrated and branched endovascular technology being used for post-dissection thoracos. So here's a paper by ARC, which is probably the largest group of IDE consortium. So if you look at theirs, they reviewed patients in this group, and there were 50 patients that were treated. This is one of the earlier results in one of the earlier reports, and they demonstrated excellent technical success. So this is not technically, something that would be prohibitive. There was no difference in mortality, spinal cord ischemia rate, survival, or target vessel patency in these patients compared to those who had degenerative thoracoabdominal aortic aneurysms. So then, what makes it a little bit different is some of the challenges that you encounter when you're taking care of these patients. So some of them I've listed up here, and we'll sort of go through some of these as well through the talk. So one of the things that traditionally people were very scared about or concerned about was the narrow true lumen. Sometimes you'll have patients who have true lumens that look something like that in those pictures there. And the question then is like, oh my God, can we actually get through this? Can we get to your target vessels? So there were a lot of myths around this that made people think that this was something that was prohibitive and should not be considered for endovascular treatment. But I think most of those over time now have been debunked. So I don't think narrow lumen is a problem. If anything, I actually find it easier because your wires have nowhere else to go but fall into the target vessels, because there's really not enough room for them to go anywhere else compared to the degenerative, which if it is 6 centimeters, you actually have to for your target vessel. So those actually have been very easy. This is an example of one of the patients that we did. As you can see that, we advanced our device, and we were able to, once you open the device, your wires literally will fall straight into your target vessels. We traditionally used to rupture the septum. I still use that technique in some of the dissections where you can rupture the septum. And once you have that, you can basically go ahead into your target vessel stenting, and that works very well. And as you can see here in this picture, the true lumen expansion is actually very good once you're done with these cases. Here you can see the difference between the pre and the post-operative images. So that is not a problem, we learned, and actually that does make the procedure somewhat a little bit easier. What about when you have false lumen, when you have target vessels that are originating from your false lumen? So that again is not an issue because there's so many tears, so many re-entry tears throughout, you may just be able to find one right next to the target vessel. If you can't do that, one of the things I really like to do and very frequently will use is, you can use a steerable sheath and the back end of a rosin wire, which is a reasonably stiff wire, and you can just poke through the septum at the side of the target vessel. You use your CT fusion, you use your IVIS to mark where that vessel is, and just go adjacent to that, and you'll get into the false lumen and be able to do that. People have talked about using Roche or TIPS needle. I've never really had to do that. I think the steerable sheath works pretty well. In more recent times, in the last 1 to 2 years, thermal septotomy has been popularized as well. This kind of stems from this paper from Dr. Khan that demonstrates using the Estato wire, a denuded portion of it that sits right across the true lumen and the false lumen, and it's insulated, and then you can use electrocautery to basically take care of the septum, basically destroy the septum and tear it down, and then that basically converts it into a degenerative thoracoabdominal aortic aneurysm, which then you can just treat as per usual. The benefit of this is that it can allow you to create a landing zone in patients where you're trying to not necessarily have too much coverage. It can facilitate branch cannulation, so you don't have to use some of the techniques that I described earlier, and especially if they're coming off of the false lumen. It can help create landing zone in the proximal extent as well as in the distal extent. So I think this technique has its place, has its role. It's a good way to be able to address that. Now, sometimes you have dissection that extends into the visceral as well as the renal vessels as well. And then in those patients, one of the things I like to do is, it's not prohibitive, but sometimes they will have retrograde endoleak from the false channel if you're just stenting the true lumen. So one of the techniques I've used is you get into the true lumen, you get into the false lumen, you can either coil, embolize, or put a plug into the false and then stent into the true. So this is one of the patients who had an SMA, and you saw how atretic it looked on the previous images. But once it's stented, it actually looks pretty good, and it's ready for you to proceed with your fenestrated or branch endovascular repair. This is kind of what it looks like. Now, we talked a little bit about spinal cord ischemia earlier. So most of these patients will have extent 1, 2, or 3 thoracoabdominal aortic aneurysms. So they've had previous repair of some sort. You can do a TVAR, you can stage them. I think staging helps, and there's plenty of data out there that shows staging is very protective. One of the things with these patients is they will, for a very large part, will have extension of their dissection into the hypogastric arteries, into the common iliac arteries, and when that happens, you're going to have degeneration or aneurysmal changes of the common iliac artery, and then you need some sort of a landing zone or some sort of a way to address the distal, the iliac arteries as well. So you can use that to stage it, not finish your procedure entirely, come back and do it a month later. Sometimes I do that. You can also extend it into the true lumen but not completely eradicate the false lumen and use that as a channel to go back and take care of some of the lumbar arteries later. Or you could just go ahead, like in this particular patient who had particularly hostile abdomen with post-dissection thoraco with bilateral common iliac artery aneurysms. I decided to do the FEVAR portion, and she had 3 branches, and then we did the right IPSI IBE to address the right common iliac artery aneurysm and the left IPSI IBE for the left common iliac artery aneurysm. And as you can see here, this is kind of his final repair, and the aneurysm has had shrinkage since then. He's done very, very well. This is a study. There's multiple studies that have come out, single center studies, but the numbers have generally been small. This is the largest study, 246 patients. This is the International Aortic Research Consortium, and they demonstrated that the results are actually fantastic. They quoted a mortality of 3%, so nothing that's really different than the degenerative post-dissection, degenerative thoracoabdominal aortic aneurysms. And they did say that the major adverse event rate was 28% in this entire cohort, which is again in line with the data that was presented earlier in the previous talk. Interestingly, they also showed that secondary reinterventions are high in this group of patients, but majority of them were minor re-interventions and not major re-interventions. So, and complete false lumen thrombosis was noted in about 60% of the patients. So overall, I think I would conclude that, endovascular repair of post-dissection thoracoabdominal aortic aneurysms is feasible. I would say that, we're still learning. The previous data that I showed you had mean follow-up of 24 months. So I think we're learning. We're evolving with our experience. We've made a lot of changes and we've made a lot of progress. One thing we know is that it does require multidisciplinary approach, as Dr. Odrich pointed out earlier. And most of these procedures, I do require multiple stages as well, and that is very protective from a spinal cord ischemia standpoint. There is increased risk of reintervention, so lifelong surveillance is extremely important. It's really important to make sure your patients understand that if they're going to get this procedure, they have to come back for follow-up, because you cannot tell them, you're done, you're cured, you're fixed. So I think there's progress, there's promise, and that's what I have for you all about the post-dissection thoracic today. Thank you for having me here. Appreciate the invitation.